We're now discussing the role of general practice in the future NHS, and this is one of the hot topics always of political and policy discussions, because it's the way in which so many people relate to and understand the NHS. But that is changing and has changed hugely over the past few years, and will obviously play a huge role in the shift that we have been discussing so far this morning, or should play a huge role in that shift. And Bex Fisher, who's Director of Research and Policy at the Nuffield Trust, is going to start us off with a presentation on the core functions of general practice and how it's changed in the past decade. I'm told this is going to be a short presentation, so good luck to cramming all those major changes into something that's described as short. But I'll let you get... Yeah, selective. Thank you, Bex.
Hi everyone, it's a pleasure to be with you. I am also a GP. I'm going to get that in there as a kind of disclosure of interest here. We're going to spend a bit of time this morning talking about the role that general practice should play in the future of the NHS, and I want to just contextualise that with a bit about where we've been in the last decade. But I wanted to start by trying to comprehensively answer the question of, is it a good idea that general practice should continue to, and indeed play more of a role in our health system in the future? Unequivocally, I think the answer to that is yes. There is a wealth of evidence from this country and internationally that suggests that health systems that are rooted in strong primary care, and for that in a UK context read general practice, are more efficient, they're more equitable, they're more cost effective, they achieve better patient outcomes. But then we have to ask ourselves, well, what does it really look like to have a health system that is rooted in strong primary care? Fortunately, academics have answered that for us as well, and I'm actually going to draw on the work of an American academic called Barbara Starfield, who in the 1990s came up with a framework called the 4 Cs that really has not been superseded since. And she said that health systems that achieve strong primary care are first contact, so general practice or primary care is the main entry point to the system and the interface between the population and the health system, that they offer continuous care or a continuity of relationship between a provider and a patient, that they're comprehensive, that you can go to your primary care provider, GP, and receive a full range of services across your life course from cradle to grave, and that they're coordinated, that they play a role in holding care between hospitals, community services, general practice, and other parts of health and care systems that patients will intersect with. So what I want you to just think about for a second is, do I recognise those features in general practice within the NHS? These are the features that strong primary care is associated with. I can see a couple of nods, and I'm going to suggest that theoretically at least, those of you who are nodding I'm in agreement with. I think that in this country, we have fairly high fidelity to these models of high-performing general practice. Gatekeeper can be thought of as a dirty word in healthcare. I'm not very sure that it is. And we have a tight gatekeeper model. Except for emergency care, people in this country see GPs to get referrals to specialist care, and GPs hold care for patients. We have mechanisms for continuity of care. We might talk more about whether or not they're working particularly well, but all of our population are registered with a GP service, and they will have a named accountable GP. Whether they can see them or not, I accept, is a different matter. We have national contracts that make sure that we have a comprehensive offer of services available through general practice, and at least some standardisation, so we know what hours our GP surgeries are going to be open for. And we have mechanisms for continuity. GPs have historically been very early digitisers within the NHS. We have complete adoption of electronic health records, very paper-light, and we have national contracts that require, for example, how long it can take for a hospital to send us a discharge summary. Again, some problems in implementation, but mechanisms at least. So I would put it to you that theoretically at least, we have fairly high fidelity to models of high-performing general practice. And yet, all of us will recognise these headlines or have experienced this ourselves for either as individuals or within our families. It's too hard to get GP appointments, public satisfaction with general practice is at an all-time low, and GPs aren't very happy either. In fact, they're taking collective action at the moment, and many are cutting their working hours in response, in large part, to workload pressures. So, as we move on in our panel discussion to think about what role general practice should be playing, and indeed where the foundations are at now to enable us to play that role, I just want to talk a little bit about what's happened in general practice in the past decade for some scene setting. Activity in general practice has risen significantly. So the total count of appointments in general practice in the last month that we have data available for, that was November of last year, there were 31 million appointments a month. For context, pre-pandemic, it was more like 26 million. And that trajectory just kind of looks like a steady upward graph with a little bit of seasonal variation. But the number of full-time permanent GPs has flatlined since 2015. Therefore, each GP is caring for more patients. On average, GPs are now caring for 7% more patients than they were in just 2019. That said, there has been a massive expansion in other direct patient care staff. So you may have heard me say massive expansion in activity, same number of GPs. What's happening? Well, actually, a lot of appointments are no longer being delivered by GPs. So my colleague, Billy Palmer, who's sitting towards the back, I think, produced this chart. It's pretty stark. You don't need to pay a huge amount of attention to the detail other than two things. So what you're looking at here on the x-axis is time. The y-axis is the change in staff numbers relative to a 2015 baseline. I want you to just look at the blue line at the bottom. That's full-time equivalent permanent GPs. And the purple line, that's other direct patient care staff in general practice. So these are people who aren't doctors and nurses but are working in general practice. And it has skyrocketed. So in 2019, there were 12,600 people working in these roles. Now it's more like 50,000. That's largely because government brought in a scheme where it reimbursed GP practices for the cost of employing these staff. So they're effectively free to GP surgeries. So we have this massive expansion in, for example, physiotherapists, paramedics, social care, social prescribing, link workers, care coordinators, 17 different staff groups brought into general practice in a very short period of time means there are real changes for how we work within our teams in general practice, but also changes for how we as patients experience the services we get from general practice and who we're likely to see. And there are other changes within general practice as well. Fewer GPs want to be GP partners. That means to have ownership stake in a surgery. So back in 2015, 67% of GPs were GP partners. Now it's 48%, and it's a steady downwards trajectory. Fairly, as you would expect to follow from that, the number of GP surgeries is decreasing. We're losing about 50 GP surgeries a year, so there's a trend towards bigger GP surgeries serving larger patient numbers. And then the way that people are accessing general practice has changed. So many of you will have experienced this. Perhaps even as recently as pre-pandemic, you might have walked into a GP surgery or phoned, tried to get through to a receptionist, asked for an appointment. Now you're much more likely to fill in some form of online form, have that triaged by a clinician, and be told what type of appointment you have. It's more likely to be on the phone than it was pre-pandemic, although the proportion of face-to-face appointments in general practice remains at around 66%, has been fairly stable for quite a while now. But it's also more likely, as I said a moment ago, to be with a member of staff who is a clinician but not a GP. So significant changes in how people are experiencing general practice, and some changes in what people seem to want as well. You'll hear many GPs like me speak very highly of the value, or we perceive the value of continuity of care, and there's a huge amount of evidence to suggest that for certain patient groups, that ongoing relationship between patient and clinician is extremely beneficial to patients, but also beneficial for health systems as well, because it gives better patient outcomes and overall save costs. But fewer people want it. The GP patient survey surveys about 700,000 people in England each year and shows that last year just 33% of people said that continuity of care mattered to them. Of those, only 40% were actually getting it. So changes in what people want as well. And very briefly, just to say that some things haven't changed very much over time either. This is one of Sally's graphs. What you're looking at here shows the proportion of spend on different parts of the health sector. And all I'd like you to focus on, for this session at least, is that yellow line in the middle. That's the proportion of spend on general practice, primary care. It's pretty constant. There's a small bump around 21, 22. That's mostly for COVID immunisations, because general practice delivered a lot of that programme. But the proportion of NHS spend on general practice in the last financial year, 23-24, was 8.7%. So it has remained fairly low over time. And the distribution of that spend between general practices has remained inequitable. So at any given age, there's more health need in deprived areas, in socioeconomically deprived areas. You might therefore reasonably expect that general practice in those areas gets more money, but actually GP surgeries in the most deprived parts of our country get on average 9.8% less funded per need-adjusted patient than GP surgeries in our richest areas. And the distribution of GPs across our country is also uneven. You will, of course, recognise that this is a map of England, and what you're looking at is the number of patients per GP. Light green here is fewer patients per GP, dark green, more patients per GP. And you'll have to take my word for it, but this does map as well to socioeconomic deprivation. So there are big areas of the country that are under-doctored, and areas that are more socioeconomically deprived have fewer GPs per head as well. So, as we think about moving more care into the community and the role that general practice can play in that, I put it to you that there are both opportunities, Isabel, and challenges. But patients are unhappy, GPs are unhappy. The shape of the GP workforce has changed significantly, not just in the last 10 years, but in the last 5, an extraordinary change. The partnership model of general practice is increasingly precarious, not necessarily because of political whim, but just because of how GPs are choosing to work. And general practice has received a proportionately and persistently low amount of system spend, and there's inequity in the distribution of that. I would like to think that as part of a shift, there are opportunities to change all that, and I'm sure we'll get on to discussing this now. Thank you.
Thank you both so much. Well, that was absolutely fascinating. Thank you so much for taking us through that so clearly. And I wouldn't say it was a select overview at all. I'd say it was comprehensive and yet swift. So thank you.
Thank you.
And you talked about opportunities, and our panel, we're now going to discuss those opportunities, some of the challenges as well, I suspect. And joining Bex on the panel are Dr. Minal Bakai, who's National Director of Primary Care Transformation at NHS England, and Dr. Joseph Betancourt, who is the President of International Health Policy and Practice Innovations at the Commonwealth Fund. So thank you for joining us both. Minal, I'll come to you first, if that's okay, about the opportunities and also the point that Bex made about the precarity of the partnership model at the moment and where you see things going, and I suppose following on from this morning's panel, how cheerful you are about the work that you're doing.
I think to stay in this job, I have to be optimistic. So I'm the forever optimist. I'm also a GP, and I'm a GP in a very deprived part of London, so the second most deprived ward in London. So I suppose in my real day job, I experience everything Bex said. We see probably 10% more need than more affluent practices. As Bex said, we're underfunded for the level of need that we're trying to provide. We have, a few miles down the road, many more affluent areas, Chelsea, Kensington, Fulham, so it's really difficult to recruit where we work. And it can be very, very difficult to retain staff because of the pressures that everybody is facing. And what I would say is that about 6 years ago, we as a practice were asked to merge with a practice that had been deemed CQC inadequate. So we overnight took on many more thousands of patients, but not with the same increase in our capacity, and that really tipped us over. So overnight, our access just fell, waiting times were about 6 weeks to get an appointment, continuity disappeared, staff were firefighting all of the time, and what we knew was that those with the sharpest elbows were getting through, getting the appointments. And it was not sustainable. It was not personally sustainable, and it was not sustainable for us as a practice. And so we had no choice. We were, the burning platform was blazing, and we had to transform the way that we worked, and we did. And we moved to what we call now, in policy terms, modern general practice. And what that means is that it's got 5 key components, but we changed the way that our access worked. So we embedded online access alongside telephone and face-to-face. When anybody contacts us, we understand their need at the point of contact. So that's both understanding their, presenting symptoms and the acuity, but we combine that in our practice with population health data. So understanding about the complexity of that need. So are they a frail patient? Do they have severe mental health issues? Are they pregnant? Are they, fit well otherwise? And we use that information to then support care navigation and triage. So we moved away from a first-come, first-served model to really thinking about how we optimise use of our workforce. And that might be the workforce within our practice, but it might also be community pharmacy, other community services that we have access to. And that's really helped us maximise or make full use of the multi-professional team that Bex described has come into general practice. But it's also helped us be more thoughtful about the skills that we need in our team. So we've really taken that data-driven approach, really understanding the types of need that's coming into general practice, the types of skills that we need, but also we've seen the shift to more complex multi-morbidity, particularly because we've got an ageing population, but also particularly working in a deprived area where we've seen a decline in the welfare state over the last decade or so. That's really impacted on people's health, and then that's been exacerbated by the pandemic as well. So we have some of the highest prevalence of diabetes, cardiovascular disease, cancers, but all the really bad ones with the poorest prognosis, severe mental illness, etc. So we've got a lot of complexity, and what we've really focused on is less about volume but value. So how do we use the workforce better, our most precious asset? The 60% of the NHS budget is spent on workforce to really add the most value. So our experienced clinicians, for example, our GPs, are really focusing on those most complex patients, but we're not asking them to do 50 consultations a day with the most complex patients. They might do half of that, but we're much more comprehensive in the way that we provide that care, and we're designing in for continuity. And then we are enhancing productivity, again, not because we're doing more and more appointments, but actually because of that workforce optimization. And that's how I sort of define productivity, because we're using the right people for the right work. But supporting that through digital technology. So about 30% of our contacts can be closed through an online message. They don't need an appointment. We use self-booking links so that people can have flexibility in booking the right appointment that meets their needs, but with the right parameters. We've got software that starts to automate some of our processes to reduce administrative burden. At the moment, we're trialling ambient voice transcription so that I can spend more time looking at my patient rather than looking at the screen and typing. And I wouldn't say that means I see more patients a day, but it certainly improves my quality of life and makes it easier to retain our staff because of the cognitive load that we're holding. And of course, the benefits of that have been huge. So our access has improved. Everybody gets, who needs a same-day appointment will get one on the same day because we're triaging. We respond to pretty much everybody within 48 hours, so we're far more responsive as a service. Continuity has jumped up from 27% to 72%. And actually what we see in kind of wider data is that the people that are benefiting the most, are disproportionately benefiting, are those that have had the poorest experience of access. So we're actually narrowing inequalities in access because we've really thought about well-designed journeys, really well-designed digital tools that make it easy for people make it easy for people to use. And if I've got a population who work 0-hour contracts, low-income jobs, it's really hard for them to take day off work or to spend time phoning up the practice. So actually, it can really support access, and so not making those assumptions, I suppose, about who can use and who can't use. But we see that both digital and non-digital users benefit equally, and so that's why I'm optimistic, because actually there is more in our gift in terms of our sphere of influence, in terms of how we can transform the way that we work. I would absolutely say I'd never go back. It's far more sustainable now than it ever was before. Staff are happier, we've got more control over our day. And for me, this is fundamental in terms of a stepping stone towards where we're heading, that kind of more integrated working, because at the same time, I am not the best person to advise someone about their finances or their housing or, you know, schools and that sort of thing. But there's a breadth of expertise within the community, and so we're now testing, you know, more innovative models using community and health and wellbeing workers, staff that have really got to focus on that proactive care, not just reactive care, to do some of that outreach work with our communities. And, you know, stepping back, national hat on, I see this around the country. So the challenge is, how do we make sure we spread this so everyone can benefit? And it is spreading. But how do we make sure that we're not just investing in the stuff, whether that's workforce, technology, whatever it is, but we've really got a strategy on how we realise benefit from all of the inputs that we're putting in.
Can I ask how much social prescribing you do? You mentioned, you know, that actually it's much better for a GP to signpost a patient to experts within the community rather than have, you know, a 5-minute discussion on debt before sending them on their way. How much is that now embedded into your practice?
So we love our social prescribers, and they're absolutely fully embedded into our practice. But actually, I think what we're moving towards is sort of health and well-being coaches who are not, who have the knowledge that social prescribers do, but it's broader. So they're actually health coaches as well. So if you take a GP as a generalist in a clinical sense, these are almost non-clinical roles that are generalists in a non-clinical sense. So that when they go to somebody's home, they can give them health coaching advice, they can give them social prescribing advice, they can give them, some kind of financial housing advice. So we're not having to have very separate roles for each of these functions. We're trying to train people to be sort of more holistic so that every contact does count and a lot more can be done during those contacts. And particularly because we've got such a high prevalence of long-term conditions, that health coaching role is absolutely critical, and we see that in international health systems. If you take sort of the NUCA health system, for example, they have, you know, a GP, a nurse, and a health coach is the core team for every patient, and then all other services wrap around that core team. So I think there is, as we move into a world where we are going to see a vastly expanding or exponential increase in long-term conditions and multimorbidity, I think we as a kind of NHS need to think about that sort of behavioural change and health coaching more seriously.
Well, Joseph, I would love it if you address some of those points about that wider health coaching, and also the point that Manal made about technology not just improving sort of the productivity of staff, but actually their quality of life so they don't leave the NHS, because you can have the most productive GP in the world for a year, but if they're not there the next year, then you know your technology is not particularly useful.
Certainly. The previous conversation focused a lot on context. Maybe I'll just begin with a little bit of context to kick us off. So I'm president of the Commonwealth Fund. We're a foundation based in New York that's a little more than 100 years old. I think and do tank, our connection to the UK is particularly through our Harkness Fellowship. We've done a lot of work internationally as well, and our focus is on affordable, high-quality healthcare for everyone. And we've done a lot of work on international comparisons, a lot of work on primary care. So I have that hat, but I also have the hat of being an internal medicine physician and a practicing primary care doctor for the last 25 years, and so I'll try to bring some of that to this discussion, as well as previously serving as Senior Vice President for Community Health at Massachusetts General Hospital, where we focus a lot on primary care and also this notion of delivering care closer to home. As a pessimist, I think it's always great to invite a system that's worse than yours to talk about the challenges, certainly because the other part of context I'd say here is that we spend 17% of our GDP on healthcare, more than any other OECD nation, and have the least to show for it. Highest infant mortality, maternal mortality, lowest life expectancy, more chronic disease, more disparities. So that's a big challenge for us, and we often reference other nations. And as it relates to primary care, our primary care spend is about 4 to 5% of our healthcare spend, compared to about 15% of OECD nations. So you have nothing but to be optimistic after you hear me. So I'd say a couple things. Everything that Beck shared is absolutely spot on as it relates to the primary care experience in the United States. However, I would argue the context for some of those challenges that we face are largely based in the way our healthcare system is not a healthcare system, and the ways in which it is very fragmented. We don't have universal healthcare coverage. 172 million people get their healthcare, their insurance through their employer, and the rest Medicare, Medicaid, a patchwork. And I say that only to say that this patchwork creates a series of different incentives for different services that I think has really disproportionately and negatively impacted primary care in the United States. So the issues that you're facing here, certainly we're facing them. A workforce that is shrinking, depleted, with more administrative burden, and largely demoralized about not being able to deliver the care they want. And there are not reinforcements on the way, as many of those who are training to become specialists, not because they don't care about primary care, but the compensation for specialists is much, much higher. And with debt burden going through medical school in the US and the cost there, those choices are being forced. And I think that's leading to a very significant challenge for primary care providers. I'd say as well, as we think about the future, certainly the U.S. has prioritized primary care. Mass General is considered one of the places where primary care was started. Barbara Starfield's work here and those components of primary care are important. So the evidence on primary care is absolutely strong and critical. Yet our investments, I think, have been very, very limited. And as a result, we see the same crisis: affordability, access, decreased workforce, all the things that you highlighted. So we are working on some of those same solutions, and we're trying to generate more activism in the political sense to create more support for primary care. But as was mentioned in the first panel, the specialists have an overweighted impact in our political system, and as such, any conversations around compensation for primary care quickly shift away from primary care to specialty care. So that context is just important. But now let me focus on some of the positive. Clearly, I think the use of technology and other modalities of delivering primary care, particularly closer to individuals' homes, are garnering more attention. We do have a robust community health center structure that was developed in the 50s in the United States based on models from South Africa, about 1,400 community health centers that are in community, comprehensive, multi-specialty, really built to care for vulnerable populations, care for about 32 million Americans. And that, I think, is the closest approximation we have to care at home and lifting up primary comprehensive care. Again, the challenge is wildly underfunded. Every year, Congress determines what the funding of these community health centers are. But clearly, I think they serve as a beacon. If we were to fund them the right way, we think we could elevate the notion of comprehensive care that meets all the different components of primary care, Bex, that you laid out, and do it in a way that is cost-effective and I think increases accessibility. But we've also began to do more work, and I could go into this in a bit, on this notion of mobile healthcare. So about 2,000 mobile vans now across the United States that are going beyond just doing kind of mobile mammography or mobile dental to mobile chronic care and mobile disease screening and mobile primary care with the digital linkage so that you could have a specialist piped in a neighborhood without the bricks and mortar investment of a community health center. And certainly we're doing more, the previous panel referenced on hospital at home and how we allow for that care of patients. Not a new model built in the 1990s, deployed here in the mid-2000s, but clearly the COVID pandemic and the need for beds drove incentives and some new regulations that allowed us to do more with hospital at home, which is exciting. But I would argue more of that is driven by the financial model, where the more beds we have open and available, the better we're able to do surgeries, which are high margin procedures for our hospitals, which are better than keeping a patient in for 12 days for heart failure. So, while the drivers might be different, there is significant benefit certainly to hospital at home and leveraging primary care and treating chronic disease in the home. So a lot of similarities. I think we'll get into some more of these as we go forward. But clearly, technology is on our radar screen. We understand we're not going to be able to solve the workforce crisis overnight, and so how do we leverage team-based care to address some of those issues? And the funding of primary care and the compensation of primary care doctors, GPs in the U.S. is a major issue for us right now on the policy side.
Thank you so much for that. And your point about team-based care obviously relates to the point that Bex made about the change in composition in general practice. Could we just talk a little bit more about retention and about what direction you feel that's going in terms of staff?
Yes, because I think it's an enormous challenge and I think we have to solve it. So I mentioned Billy's work in my presentation. Billy also did some work looking at workforce participation in primary care. So it is true that we are training more doctors to be GPs now. Many of you will be aware that successive governments in recent years have had pledges to bring more and more GPs. It was 5,000 more GPs in 2015. We didn't get there. We doubled down to 6,000 more GPs in 2019. We didn't get there either, but what we did do is train more people to be GPs. But we have to train 2 doctors to be a GP to get 1 full-time equivalent GP at the moment. So we have a big participation problem. And it's not really a crude analysis to say that driving that is workload. Is that, and I'm speaking partly from evidence, but a lot from my own experience as a clinician now, is that workload has gone up and up, complexity has increased, and people's very understandable, I think, response to that is to say, well, the way to keep myself well and to stay safe as a clinician is to do fewer hours, and that's what we're seeing in the data. So that's why that blue line at the bottom of the graph is as it is, i.e. full-time equivalent GP numbers have stagnated. And I think we've been stuck in a slightly vicious cycle here because we desperately need more GPs and activity is rising, and some of that, I'm being careful about how I use activity and demand, but consultation numbers have risen, but demand is going up as well, we think. And so we need more GPs, but how do you do that without just forcing people to make a difficult decision, which is to cut back because you've overworked them? And that is a real challenge. That influx of new staff in 2019, in some ways, could be part of the solution, but I think one of the concerns of many people is that it doesn't seem to be playing out that way. And I'm just going to stray into the political realm here. Which is to say that my sense was that by 2019, and I have no evidence for this, the government at the time had realised that they were not going to achieve their manifesto commitment on GPs. But they had another manifesto commitment, which was 50 million more appointments in general practice. And you could achieve that manifesto commitment if you put more staff into general practice. And they did achieve that manifesto commitment, and they did put more staff into general practice. One of my concerns is that what we might be doing is achieving more activity in general practice. We've gone from that 26 million appointments pre-pandemic to 31 million. Now, I'm not for a moment denying that there should be more activity in general practice with an ageing population, but my concern is that we haven't closely enough aligned the type of activity we need with the actual demands that we have. Mm-hmm. So, for example, is some of what the time of those additional staff, who are very highly skilled health professionals, is some of what their time being spent on seeing patients with minor illness that would actually be self-limiting. And we will now count that as an appointment in general practice and activity, and we are therefore doing more, being more productive in general practice. But maybe we didn't need that activity anyway. And so we are simultaneously, to bring it back to your questions about not solving our retention challenge either, because as a GP, what's happened is that I'm still working very hard. And in fact, my patient list is even more intense and demanding because anything else has gone to my expert other colleagues who are dealing with that. So I'm not sure that some of the policy solutions that we've come up with in the last 5 years are solving the problems that fundamentally need to be tackled.
Am I right in thinking that you're very politely pressing the hot button that is physician associates?
No, I don't think I was intentionally. I've worked with physician associates for many years, actually, and have very positive experiences, and I think that there really is a role for an expanded skills mix in general practice. But it came as a shock to us. So this was brought out in a contract in January of 2019 to be implemented by July of that year. That is very little time for what is in effect a colossal transformation programme in primary care. And there was very little, at the time, transformation and implementation support. A lot of this work has actually been done by my colleague Becky Baird from the King's Fund in looking at, in effect, the failure of some of the implementation of this big skills mix change in general practice, because that support didn't sit around this. So this isn't about the merits of individual professions, I think, as much as it is about how you do transformation within a health system, and particularly within general practice, how you embed those roles and what good working looks like. And I don't know, Jo may have thoughts on this, because I spent a small amount of time in the States looking at primary care systems there as a Harkness Fellow a couple of years ago, and one of the things I reflected on is that I thought they were much further ahead in team-based care in primary care, and what I mean by that is how you actually integrate direct patient care roles who aren't physicians into your workforce in a way that doesn't generate supply-induced demand by kind of adding appointments but not particularly necessarily meaningful activity, but that actually improves the efficiency of your health system. I felt that actually in some of the health systems I looked at, you were doing a better job.
Well, you're both nodding. I'll come to you, Joseph, first, and then I just want to talk about the transformational support that Beck mentioned with regards to PAs.
Yeah, absolutely. I mean, I think you mentioned quantity versus quality and value, and I think one thing that's been positive in the U.S. is the shift of paying for quality of services, not quantity. The quantity payment structure just created a grind. You see more people, acuity not an issue, the more the better, a lot of burden, but ultimately that's how compensation was made. Now the move is towards paying for quality of services, the idea of improving value, and that has allowed us to lift up through this payment mechanism team-based care. So I practice in Massachusetts. Massachusetts has been very advanced in what we call value-based contracting in these financial arrangements, and it has given us a chance to manage populations of patients by condition, so not necessarily by community, but populations of patients with diabetes, and think about what is the right deployment of a team to achieve the best outcome for those patients, or patients with heart failure or hypertension, so really focusing on cardiometabolic disease. And so fundamentally, we've attempted to build out a pyramid that includes, and everyone, the driving notion here is everybody working at the top of their license, meaning that expertise, it's not about amount of resources, it's about how you deploy those resources most surgically to the needs of patients and to achieve those higher outcomes. So we've created pyramids that allow for a physician to provide oversight, working with a nurse practitioner, a healthcare coach, a navigator, a community health worker, and those individuals work as a team to address the needs of a population of diabetics. So it could be anything from right foods and exercise to medication reconciliation to making sure they're getting basic foot care and somebody's examining their feet. So this whole set of services that I, as a primary care doctor, don't necessarily need to do, but they could be leveraged through a team, and we are compensated as a team. That's decreased the amount of patients I need to see. It's allowed us to leverage these different resources in a more specific way to meet needs, and I think it's improved satisfaction. We too, I think, are facing the burden of, post-pandemic, a lot of people not getting care, and that tsunami, I think, of seeing more and more patients, so that's real. But I think team-based care holds a lot of promise, and it has been a slow, but I think a very thorough integration. Even patients were a little uncomfortable when they called in with a cold, upper respiratory tract infection, and they were told they needed to see a nurse practitioner. There was a drop-off in trust. That trust has been built. Our patients really love the nurse practitioners. They see them embedded in teams. Our physician's assistants are more working in the hospital and inpatient care, so just fundamental difference in how we deploy it, and the taxonomy might be different here and in the U.S. But I think team-based care holds great promise. Leverage with technology, our view is that you could get even more from those team members and what they can do and what the potential is.
That's so interesting that you mentioned a drop-off in trust initially with nurses, and I think it's sort of entrenched view that the GP is seeing that patient as being less important as opposed to trying to get them the most appropriate care.
That's right.
Sounds like you've worked out how to address that.
Yeah, building that trust, and I think the trust has also been built because as patients have had more experiences, they're like, okay, I was triaged appropriately. The nurse practitioner provided excellent care for my needs, and yes, I'm still going to see the GP or the primary care physician for abdominal pain that could be more serious, or for the management of my cardiovascular disease. So I think that has been helpful. And quite frankly, with the access challenges, people are much willing to see someone than to wait 3 months if they're not feeling well.
Yeah, I mean, it's really interesting. And I think there are some reflections on the actual scheme. So the additional roles scheme, it's the R's scheme. I think when it was first introduced in 2019, I think it included just 5 roles. There were caps on those roles, so it wasn't particularly flexible over the last few years. That flexibility has increased. I think there's still calls for greater flexibility to match kind of roles to what the local population needs are, which comes back to our conversation about value and understanding your data, your demand, your need, and then being able to match the right workforce skills to that. So I think we're on that journey, but we're not there yet. I think, though, there's also, as you've alluded to, a lack of investment in transformation and improvement, not just in the R's scheme and embedding the multi-professional team, but I think in general compared to the hospitals, essentially. So I think there is the earlier panel touched on it, there's a focus on metric, like what can we measure? What we measure is then what we do something about. And because the hospitals have such great data, everything is that ICB's, the Integrated Care Board's focus is on the hospitals, and therefore the resource is focused on the hospitals. That includes any change management resource as well as funding. And so primary care, and I think general practice has probably got the most compared to wider primary care, so dentistry, optom and pharmacy, but even that is too little. There is very limited infrastructure in most systems to support transformation and improvement in general practice, let alone wider primary care. So a lot of what I've been doing is try to build that infrastructure across systems, but it's still very emergent. And what we see is it's a challenge at multiple levels. So I think we can openly talk about how even at national level the focus is still being much more on the hospitals and the acutes than primary and community services. It's only really now with the government's shift in the 3 missions that we're seeing much more focus on primary and community services, which is really welcome. But what that then means is that actually the performance management of ICBs traditionally, again, has been much more focused on hospitals and hospital performance and not about the performance in how they're improving general practice or pharmacy or wider primary care. So that needs a shift as well, because then that focuses the board's mind within ICBs on primary and community services, and then that starts to create a different conversation about how resources are embedded. And I think the other bit there is that the primary care teams within systems are also pretty small for the level of expectation that they're there to kind of meet, considering that 93% of contacts with the NHS are with primary care. I think also it's worth therefore recognising that most practices have had to do this without support, unfacilitated, not systematic, and not particularly rigorous. And that investment in improvement capability, data, digital, quality improvement skills has not traditionally happened. So again, that's starting to happen now, probably not quite at the scale or pace that I would like it to happen, but it is starting to happen. And I think we've just got to make sure we sustain that and continue to grow that going forwards. And what is quite telling, run the National General Practice Improvement Programme, so go and work with lots of, perhaps thousands of practices, is that, many people don't also really understand the scope of these roles. So even teams within general practice, like your care navigators and receptionists, don't fully understand what the role of the pharmacist is, or the first contact physio is, or the social prescriber. What's the scope of the role? So there's work there to be done as part of that embedding, so people understand what they do and then can better navigate to them. But I think there's also a wider system problem. So if, you'll have lots of people go to sort of, whether they go to A&E or an outpatient appointment, a lot of it is go back and see your GP. We're not consistent in our language. We're not going, see your general practice team, or see, the expert pharmacist that must be in your practice. It's always see your GP. So to your point, to build that trust, we need the consistency of language and communication to the public that talks about that multi-professional team, and not just see your GP.
That's really interesting, the impact that shorthand can have on what a patient then expects to happen when they go into their general practice. Bex, you wanted to chip in, and then I'm going to go to questions, so be ready.
Yeah, I guess it was just to bring it back to the bigger picture of our conversation about shifting from hospital to home and what role general practice has. It was to just build on Minal's point and say, I think it is so important that we don't overlook the transformational support that will be needed. I hope that what I succeeded in doing in my presentation at the start was giving you a sense actually of the precarity of general practice at the moment. Like, I absolutely think that it should be the foundation of our future NHS, but it's wobbly, we're building on sand. So we have to shore that up. That is a bigger set of questions around what the politics and policies are that support that and the transfer of spend. But literally on the ground, to Minal's point, and as the person responsible for running these things nationally,
no pressure.
There is a gulf between the capacity of hospitals to transform and the capacity of GP surgeries, which are primarily still small businesses run on this corner shop model with very little capacity. That's things like our grad management training scheme that trains our NHS managers, fantastic scheme. Very, very few placements in general practice. What is the pipeline through into general practice management? If we don't have that within general practice, then we're reliant on it at the next level up in the system, which is usually our commissioning bodies. Until recently, there were over 200 of them, which enabled at least some degree, by the end of CCGs, I would suggest, of local knowledge, and good local commissioners had great local understanding of the GP surgeries in their patches and could often support them. We've now shifted to much bigger ways of commissioning, just 42 integrated care systems across the country. Every time you go through these big service reorganisations in the NHS, you lose institutional knowledge and you often lose good people. And I am particularly worried at the moment that we are about to embark on something which I welcome, moving more care into communities, hopefully bolstering the role of general practice, but we're doing it at a point where we've actually stripped out a lot of the infrastructure, the commissioning support in the move to ICBs that we needed. I'm not saying the move was a bad thing, I'm just saying this is coming at a point where we have stripped out some of that infrastructure, and GP surgeries don't have the infrastructure because we are primarily small businesses. So I think it is so important that, as well as thinking about what we're going to do and how we're going to pay for it, we think about how we're going to do it in really practical terms with GP surgeries, and don't underestimate the level of support that we will need to make good things happen, because however good those policy intentions are, we consistently fall short on implementation.
Can I just add? Sorry,
Very quickly. Yeah.
Just to add to that, I think that one of the biggest barriers that I've seen going in and working with lots of practices is, time and headspace is a real issue. So, again, in hospitals, clinical staff will have PAs where they've got protected time to do work on quality improvement or service redesign, but that doesn't exist because we're focused on counting appointments or consultations, and actually there's a whole wealth of hidden work that happens, but because of that's not captured in data, we've got block contract, capitated models, that it's not surfaced. And so if we really want to take this opportunity and do it well, because there is an opportunity cost of reworking change, then we do need to create the right conditions for this, which is a lot of what we're trying to do with the systems.
Great. And now on to questions. This is just, here comes the microphone. Going straight there. There we go.
Thank you. I'm Helen Buckingham. I'm the Past Director of Strategy at Nuffield Trust, now working independently. But relevant to my question is, I'm also Chair of National Voices, which is the coalition of about 200 charities that speak with and for people who use health and care services in England. And I've been really interested in the panel, some great discussions, but what we've got on the panel are 3 professionals talking about what matters to patients. So I'm really curious, and you're talking a lot about how services need to respond to what patients need, but also how patients need to understand how services are changing. So I'm curious as to how you think the NHS should be working at both a national level, and we've got an opportunity now with the 10-year plan being delivered, and also at a local level to co-produce with patients and the public. And public expectations and patients' expectations may not be the same. So how do we co-produce with patients and the public a better future for general practice in the NHS?
Thank you so much for that question. So how do we co-produce with patients at a better level of service within the NHS in general practice? Bex, let's go to you first.
Helen, it's such a good question. I'm not going to pretend to have all of the answers here, but I am fascinated I think we need to create spaces where we can genuinely listen and hear, and by we I think that probably exists at all levels. You know, we have patient participation groups in GPs. Every GP surgery across the country will have a patient participation group and will be trying to listen to its patients. I think, you know, clearly we need to be replicating that at all levels of the health system, and I'm sure if we had political colleagues here now, they would be saying, well, the 10-year plan includes a listening exercise, and I think we will all be very interested to see what they've heard, because I think genuinely hearing and understanding people's experiences, but also their expectations, is critical. And I'm fascinated by this at the moment, because I think that there are lots of, as I would see it, and I'm going to wear my policy hat again here, slightly unresolved tensions. So, for example, a very consistent narrative is that people want faster access to GP appointments. But actually, 43% of appointments are delivered on the same day in the NHS at the moment. And when you ask people who have actually experienced care whether they're happy with the pace of their GP appointment, they predominantly are. There's a similar disconnect when we talk about access to face-to-face services. People consistently in public polling say that they don't have enough access to face-to-face services, but when you look at online triage, so when you look at what people have requested at the point at which they access general practice, people are actually predominantly requesting telephone appointments. So there are these big gaps, I think, I don't know what's going on there, but what I do know is that these big, interesting pieces of information then drive sometimes quite dominant political narratives. And so back to my original point is, I just think we have to understand more, because I think if we don't, we risk building policies around the wrong things here, and that would be disastrous, particularly given our resource constraints.
Minal, how much hearing is the listening exercise doing?
I'm not responsible for the 10-year plan, so I'm not quite sure. I know that's the ambition. I probably won't be able to really give a view on how effective it's been so far. I mean, I think Helen, it's a brilliant point, and I think we're on a journey. If I'm really honest about how much co-production is happening with patients, but I think some of the things that I've seen that have been really good are, for example, a lot of what we're discussing, there's no real right or wrong answer. There are trade-offs with all of this. There's no perfect solution. So there have been lots of deliberation events. So like London, for example, where I work as a GP, has held a series of deliberation events, which are which bring together, a broad sample of Londoners basically into the room and, present the challenges that people are having with regards to kind of policy development. You could do this, but these are the trade-offs, these are the things that would happen and not happen. And have those quite honest and open discussions where you deliberate those trade-offs. What are the red lines for the public? What are they willing to accept? What are the caveats that would go around that? And that's been really useful to try and help inform and steer in a much sort of deeper way. Where the programs that I lead, one of them is about peer leadership. So there are lots of people who have lived experience that are really, we heard about volunteering, but people who have with lived experience are really keen to influence policy and strategy, but kind of don't know how. And so there's a development program for peers, there's a peer network, and then from that there's sort of what we call a strategic co-production group. So people who also have been trained in the sense that they feel confident in some of those spaces at a board level, for example, to be able to remind everybody why we're here, bring the patient's voice into the conversation, not necessarily representing all of the public, but getting people to remember why we do what we do, which is so important. And a lot of what I have done, particularly in the user research space, is community user research. So again, working with community partners, voluntary sector, charities, and researchers to go in to be able to reach out to some of those communities that wouldn't traditionally, the NHS may not have traditionally engaged with, to really make sure that what is being designed is not just meeting the needs of the people who've come into the room, for example, or who felt comfortable going to a deliberation event, but actually those that haven't, or have other kind of access or communication needs, to really broaden the way that we do things. And I think how do we can only go further with this and make sure we embed that much more systematically going forwards and start to build those skills or embed those skills again at every level of the organisation. So journey, can't really give you a view on the 10-year plan though.
Okay.
I think that just the last thing I would say is that also measurement, like we need to start measuring what matters to people. So, when we talk about like even cardiovascular disease prevention, and this is again something we do locally, loneliness has the same level of risk as not taking your statin and having a high cholesterol. But we measure your lipid level, we don't ask about loneliness. So if we're really true to providing that holistic whole person care, we need to measure what matters to people.
No, I think that's spot on. We're very focused on that co-creation. We've talked a lot about patient-centered care, but it's been what the individual patient wants, not real co-creation of bringing patients' voice into what the system might look like. And I do believe that the system, how we think about primary care, will evolve exponentially in the next 5 to 7 years, with generational differences in what access looks like and what people want, with some of the needs of older individuals. I think practice is going to look very different. And the question is, will we build a payment models regulation workforce to meet where primary care needs are and where it's going?
Well, we are now at the end of this session, I'm afraid, and I have promised to keep this event to time. So look, thank you so much to our panel for such an interesting and detailed discussion, and I think quite a hopeful one as well. Actually, we've got one on social care next, so don't get don't get too comfortable. But we're going to break for refreshments until 11:20, when we'll come back in here for our social care discussion. So just give a round of applause to our panel. Thank you.